our academic coordinator, Dr. Murugesh Lakshman, to say the pediatrician's prayer.
Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, all times, and amidst all people. Thank you, sir.
Thank you very much, sir. Now I request our President, Dr. Balashikar, sir, to inaugurate today's session.
அனைவருக்கும் இனிய மாலை வணக்கம். அனைவருக்கும் இன்றைய ஆயுத பூஜை விஜயதசமி நல்வாழ்த்துக்கள். I'm very happy that so many people have assembled on this auspicious day. I can imagine how much you people are willing to learn new things. Actually, ஆயுத பூஜைக்கு ஏதாவது புதுசாக கற்றுக்கணும். இன்னைக்கு நிஜமாவே நிறைய கற்றுக்க போகிறோம். Through Dr. Kannan, Kanimoli, who are both our pediatric radiologists, and Dr. Sudhakar Karnakaran, who is a neurologist. And today is the first time we are venturing into this OSCE area. Today we are going to see about OSCE in pediatric radiology of head and neck region. And we have got two brilliant students with us who are from KMCH, Dr. Hema and Dr. Renuga. I should thank everyone from KMCH for accepting to do this, especially on this auspicious day where you people are be busy celebrating. In spite of that, you have accepted to do it. Thank you very much. I think we will have a very good learning experience today. Thank you very much for the opportunity.
Thank you, sir. Now I request our academic coordinator, Dr. Murugesh Lakshman, to conduct the proceedings. Over to Dr. Murugesh Lakshman.
So I request Dr. Sudhakar Karnakaran to start the proceedings, the mentor for today's session. Sir, Sudhakar, sir.
Yeah. அனைவருக்கும் இனிய மாலை வணக்கம். My warm greetings and wishes to everyone on this auspicious day. It's wonderful to learn some new things in radiology, which would be very useful for all of us in our routine emergencies, OPD practices, where in the busy practice, this radiology will take us to the next level of investigations. And it's very important that we know the red flags in the radiologies, and we know to keep those cases as we should keep them apart, and we should try to investigate further. So we should learn about what are the emergency radiology procedures and how to go ahead, and what are the specific investigations we have to go ahead. So I think it would be a good, without wasting much of the time, I once again thank the organizers for giving me an opportunity to be a part of this session. Now I welcome the resource persons, Dr. Kanimoli and Dr. Kannan. Over to you, sir. Yeah, thank you.
Thank you, sir. We now request, we'll start the session with Dr. Kanimori's X-rays. So over to Dr. Kanimori.
Sorry, I was muted. So yeah, I was just saying, I want to thank the IAP team for having me here today. And in this session, we're just going to look at some basics of pediatric X-rays. I'll cover chest and abdomen in this talk. So the format will be, first, we look at some common pitfalls or things that you see commonly in pediatric X-rays. And then we look at some cases. So there are some PGs, is it? We'll be answering questions.
That's fine.
Okay, fine. So the first few X-rays, I'll just cover a little bit.
Yes, ma'am. We have got PGs actually, with whom you can discuss also as you go ahead.
Right. Okay, so when we get to the cases, they can maybe interact, and then we'll have an interactive session. So looking at chest X-rays first, so we all know that in children, it's mostly supine AP radiographs that are done. So whenever you look at an X-ray, have a system. So make sure you look at all of the structures. You either go from outside to in or in to out, but make sure you cover everything. So if you're going to go from in to out, look at the trachea first, and then the mediastinal structures, the hilum, the heart shadow, and then the lungs. So when you look at the lungs, always compare the two sides to see if it's equal or there any differences. And then finally, don't forget the bones. So here are two X-rays from young children. Now, both of these are supine X-rays. So in both of these X-rays, if you look at the trachea, are you able to make out that there is a slight deviation to the right side? Now, this is a normal finding in young children. It's known as a normal tracheal buckling to the right. And the reason for this is that it's a combination of factors. It's because of the left-sided aortic knuckle, and also the left lobe of the thymus will have an extension upwards. So both of these together will produce this. If you see this in older children, then you need to be concerned whether there is a mass or some lesion there that's pushing the trachea. But in young children, this is a normal finding. So here are two X-rays from neonates, again demonstrating a normal finding that you see. So are all of you able to make out this line running across the lung? Now, is this a pneumothorax? No, so these are normal skin folds. So in neonates, they have quite loose skin, and when the X-ray cassette is placed underneath, the skin will fold and give rise to this appearance. So how are you going to differentiate this from a pneumothorax? So skin fold will have a broad opacity. It won't be a thin line. It will be a broad opacity that slightly fades towards one side. And the important thing is beyond this line, you should be able to make out lung markings. And then the fold will not follow the expected course of the pleura. So if you were to follow this fold, you'll see it going outside the lung into the chest wall. Or if you trace it downward, you can see it go down into the abdomen. So these are the things that tell you that this is not a pneumothorax. So in contrast, in a pneumothorax, the visceral pleura will be seen as a thin line, and beyond this line, there will be no lung markings. So here's a skin fold in a similar location. If you compare the two, you can see the difference. The skin fold is seen as a thick opacity, and beyond that line, you're still able to make out lung markings. Another example of a pneumothorax, again, you can see the visceral pleura as a thin, sharp line, and beyond that line, there are no lung markings. Here's a skin fold in a similar location, and this skin fold you can see is a broad opacity instead of a thin, sharp line. And if you follow that line down, you can see it goes beyond the lung field and extends into the abdomen. So here's something else that you see very commonly in young children. This was a 2-month-old with cough and fast breathing. So this mediastinal widening is the normal thymus. Now here's a zoomed up image of the same. So if you look at this opacity, you can see that it is not totally white. It is not completely opaque. There is some degree of lucency to it. So through this opacity, you're able to make out these white lines. So these are vessels going across. And the reason you can see these vessels is because there is some lucency to it. If this were a mass or consolidation, it would be totally white. You wouldn't be able to see the vessels through it. So this tells you that this is a normal thymus. So what are all of the features of a normal thymus? So we already said it's not densely opaque. You're able to see vessels through it because it has some lucency to it. If you look at the lateral border of a thymus, it'll have a wavy contour. Now, the reason for this is the thymus is a very soft structure. And when the anterior ribs come down, they'll indent on the thymus and they cause this sort of wavy contour to it. And the most important thing is that a normal thymus will never have any mass effect. So if you look at the NG tube in the esophagus, you can see that it's not being displaced or pushed across to the other side. So thymus will never displace any structures. Whereas if it's a mass, you would expect some displacement of your trachea and the esophagus. So the thymus is largest during infancy, and after 2 years, it starts involuting. By the time the child is about 8 years old, it becomes quite difficult to see a thymus on the X-ray. If you were to do a CT, you'll still see that sort of triangular thymus in the anterior mediastinum, but on an X-ray, it's quite difficult to see a thymus in an older child. And this is your typical sail sign of the thymus. And the reason you see it is this is the minor fissure. and the thymic tissue becomes limited by the minor fissure there, giving rise to this typical triangular opacity known as a Sale sign. Okay, so we'll look at some cases now. So here's the first one. This is a 4-year-old who has fever for 5 days. So do one of you want to tell me what you find on this?
There is opacity in the right upper limb.
Yeah, good. Okay. So with that history, what are you going to call this?
Consolidation.
Yeah, consolidation where?
Heterogeneous left upper zone.
Right, you mean. Yeah, this is your right side.
Right, yes, ma'am. Right upper.
Okay, so this is right upper lobe consolidation. Now you need to remember that the word consolidation does not equate to infection. So what consolidation really means is that there is no air in the lung. The air in the lung has been replaced by something, and that is why it looks white on an X-ray. So that something that's replaced the air can be any of these. It can be fluid, it can be pus, blood, or tumor cells. And which of these it is will depend on your clinical history. So because this child has come with a history of fever for 5 days, you assume it's infective consolidation. Now, if the same child had a history of trauma and this is an RTA case and you see this, you would assume this is blood or fluid in the lungs. So consolidation just means that the air is being replaced by something, and you need to have clinical context to tell you what it is. So please remember that consolidation does not equate to infection. Always correlate with the clinical history. Now we know this is the right upper lobe because anatomically that is where the right upper lobe is. And the sharp line that you see here is your minor fissure. So all of this tells you this is in the right upper lobe. So here's a 2-year-old who has fever for 3 days. What does this show?
Right side opacity involving the right upper and middle lobe.
Now, what is different between this and the previous X-ray that we saw?
This is homogeneous.
Yeah, the last one's also homogeneous. So what are these arrows pointing to? Now, in the last X-ray, what did we say? How do we know that was in the right upper lobe? What was that sharp line at the bottom we said was?
Fissure.
Yeah, the minor fissure. So this arrow here is pointing to the minor fissure. Now, in the previous X-ray, you saw it somewhere up here. Whereas in this child, you can see the minor fissure is bulging down. So what is this? So this is again right upper lobe consolidation. This is your bulging fissure sign. And the reason it's bulging is because of thick exudative secretions that will cause lobar expansion and cause the fissure to bulge down. So which organisms do you need to think of when you see this bulging fissure sign? Typically, it will be Klebsiella streptkin. Yeah. So here's another example of your bulging fissure. Again, there's right upper lobe consolidation. And you can see that the minor fissure, instead of being horizontal, is being pushed down and it's bulging down. Okay, here is a 6-year-old who has fever and cough for 2 days. What do you see in this?
Right upper lobe collapse.
Yeah, good. So why are you saying this is collapse?
Right borders. Homogeneous opacity.
Sorry, I didn't hear that.
Crowding of its.
Crowding of ribs. Where do you see the crowding?
Golden is
Right upper lobe.
Not really. So if you compare the rib space here, so there's one rib, there's another, that's the space. And then the
And
same
there's no
on the
air
other
program.
side.
There's no air program.
So the air bronchogram, you can see in a consolidation. You may not, but you can see an air bronchogram in a consolidation. You may see that in a collapse also. So that you cannot use to differentiate. So what tells you that this is collapse is this line. Again, so what is that arrow pointing to?
horizontal fissure.
That is the minor fissure. So in the previous cases, you saw the minor fissure was either flat here or in the bulging one, it got pushed down. Whereas in this one, you can see the fissure is pulled up. So the fissure is pulled up indicates that there is volume loss. And that is what the definition of collapse is, that there is volume loss. So these are the 3 cardinal signs of a collapse. So displacement of a fissure tells you that there is loss of volume. And then you're looking for crowding of vessels and bronchi in that collapsed lung segment, and hyperinflation of the remainder of the lung. So if you compare the two sides, the right and the left, are you able to make out that the remainder of the non-collapsed right lung is much darker when compared to your left lung? The reason it's much darker is because it is hyperinflated. So the upper lobe is collapsed and the middle and the lower lobe are hyperinflated to compensate for that collapse. So collapse, we already said, the meaning is that there is volume loss. So what is atelectasis? So generally use the term collapse when an entire lobe or an entire lung is collapsed. And atelectasis is the term used for partial collapse. So only when a segment or a subsegmental collapses happen, use the term atelectasis. So what are the causes of collapse? It can be because of an endobronchial obstruction. In an adult, you'd think of a tumor, endobronchial tumor. In a child, you're not going to think of an endobronchial tumor. The commonest things in a child would be foreign body, and then mucus plugs. And also if there's some infection, you can get inflammation and stenosis of the lumen of the bronchus that can cause a collapse. Now, without obstruction, you can get collapse that is known as passive collapse. And that is going to happen when there is a very large effusion or in the cases of a pneumothorax. So here's the next one. This is an infant who had cough and wheeze. So what is your finding here?
Right upper lobe collapse.
Yeah, very good. So again, this is right upper lobe collapse. And again, you know it's collapsed because that fissure has been pulled up. And if you look at the lung, can you see it's much darker than the left side? So there is compensatory hyperinflation of the remainder of the lung. And all of this tells you that this is collapse. So sometimes when more than one lobe or there's a lot of collapse, you can also expect to see mediastinal shift. That hasn't happened much in this, but that is another sign to look out for. So the mediastinal shift will be towards the side of the collapse. Okay, here is a 9-year-old who has fever. What do you see? So you've got two lungs, always compare the two sides and see if you're able to make out a difference.
Right side is more hyperinflated as compared to the left.
Yeah, you're right. The right does look darker. But what else can you see? So I'll give you a clue. The pathology here is on the left side. What can you see on
Crowding
the
of ribs over the left side.
So no, yeah, I see what you're talking about. Here you feel that it's crowded. So that's because child is rotated. So that's not pathological. What else is there? So if you look at the left lower zone, are you able to make out that it's a little bit too wide? So compare the lucency. So this is the right side of the heart. So if you compare the lucency behind the right side of the heart to that on the left, are you able to make out that there's a difference? So on the right, can you see it looks a bit grayish, whereas on the left side, it looks much whiter than on the right. So what you see here should be the normal lucency of the lung, whereas on the left, it's much too white. And the reason is that there is consolidation in that lower lobe. Now, you know this is the left lower lobe because one, that is the location of the left lower lobe. And the other thing that tells you this is in the left lower lobe is the diaphragm contour that has been obscured. If you compare the two hemidiaphragms, on the right, you can see the diaphragm contour really well. But on the left, if you trace the diaphragm, you can see it until there. After that, you've lost the contour of the diaphragm. That again tells you that there is some pathology in that left lower lobe. So all of this tells you that this is left lower lobe consolidation. Now, you've often heard the term retrocardiac consolidation. Now, the reason it's called retrocardiac is because if you look on a lateral X-ray, so this is a lateral X-ray, there is a spine and that is the sternum, and there's your heart. So the normal location of your left lower lobe is behind the heart. So it's retrocardiac. That is the normal location of your left lower lobe. And because the consolidation happens there, it's called retrocardiac consolidation. So here's another example of left lower lobe consolidation. Again, you can see that behind the heart on the left side, it's much too wide. And if you follow the diaphragm, you can see it until there. After that, the diaphragmatic contour has been lost. So these are the two things that you look for to diagnose a left lower lobe consolidation. So look for the opacity and also the obscuration of the diaphragmatic contour. So here's a 10-month-old who has fever and cough. What is the finding here?
Hyperinflate.
Bronchiolitis.
You're right,
Bilateral
hyperinflated. Which
hyperinflation.
lung is hyperinflated?
Left side.
Left side.
So just compare the two sides and do both sides look equal or one is more than the other?
Right side is hyperinflated.
Okay, so you feel the left is not.
Left is hyperinflated than right.
Yeah, so how do you know that this is hyperinflated?
The diaphragm contour is lost.
Yeah, very good. So the couple of things that will help you decide hyperinflation is one is the lucency. How dark does it look? So these lungs look quite dark. So both sides, it's hyper. So that's known as hypertransradiant. That's the right term to use. And then if you look at the diaphragm, you can see the diaphragm is depressed on both sides. So instead of bulging up like this, you can see both of the diaphragms look depressed and pressed down. And another thing you can see, it's not there on this child, but another sign to look out for is the bulging. You can see the lung bulging out between the ribs. That also tells you that there is hyperinflation. So you've got bilateral hyperinflated lungs and there are prominent bronchovascular markings. So what is your diagnosis here? This is typical for what? Hyperinflated, bilateral hyperinflated with prominent bronchovascular markings.
Hyperreactive.
Bronchiolitis. Okay, so that's the typical finding in bronchiolitis. Here's a 4-year-old who presented with sudden onset of cough. What is your finding here? So again, compare the two sides and see if you can make out a difference.
Right side hyperinflation.
Yeah, very good. So right side hyperinflation. So unilateral hyperinflated lung with that history, what are you going to think of?
That's mediastinal shift.
Foreign body.
Yeah, good. So it is going to be typical for foreign body. So unilateral hyperinflated lung in a child who's presented acutely, always you need to rule out a foreign body. Here's another example of a foreign body, and you can clearly make out that the volume of the left hemithorax is increased. It's much darker compared to the right side. And if you look at the diaphragm, it's depressed down. So all of this tells you that there's some obstructive phenomenon going there. It's because of air trapping. So the foreign body will let air get into the lung, and then during expiration, there'll be a ball valve effect and the air can't escape out. So because of the air trapping, you get this hyperinflated increased volume. So what we saw on the two previous X-ray with the hyperinflated lung is the most common presentation of a foreign body. But rarely you can get complete obstruction also, as in this case. So this was a 3-year-old came with sudden onset of cough and distress. And you can see here, there is complete whiteout of the lung. So there is collapse of this lung. There is some mediastinal shift also towards the right side. And this was a case of foreign body obstructing the right main bronchus. And it was removed after bronch. And you can see that both lungs are equally inflated after the removal. So just bear in mind that rarely you can also get collapse of the lung with a foreign body. Okay, here is a 1-year-old male with respiratory distress. So again, compare the two sides. What do you see?
There's mediastinal shift to the right.
Yeah, very good. So the first point to note is that there is mediastinal shift.
And one left side hyperinflation.
Very good. Okay. And what else?
Effusion.
So how is this difference? If I go back to the foreign body X-ray, so this also has hyperinflation in the left lung. And you're saying this one also has hyperinflation. How is this X-ray different to that one with the foreign body? What is this that you see here? So this is the collapsed left lower lobe. Okay, so in that X-ray with the foreign body, you saw that the entire lung was hyperinflated. Whereas on this X-ray, yes, there is hyperinflation, but you're also seeing this tissue here at the bottom. So that is the collapsed left lower lobe. So that means only the left upper lobe has been hyperinflated. And this line that you see going across, you can see some lucency extending across. So that's transmediastinal herniation of the left upper lobe. And then there is mediastinal shift. So the thymus and the heart has been shifted to the other side. So what are these indicative of? Hyperinflated lobe, mediastinal shift. Yeah, so this is CLE of the left upper lobe. Now, if you were to do a CT, this is what you're expecting to see. So again, on the CT, you've got very hyperinflated lobe and the vessels are attenuated. So very thinned out, widely spaced vessels. Now, this is different to a CCAM. In a CCAM, what you're expecting to see is normal lung, and then the abnormal area has multiple cysts within it. Okay, so some people get confused between CLE and a CCAM. In a CLE, you have a lung structure is normal. It's hyperinflated with attenuated vessels. Whereas in a CCAM, the involved region of the lung is abnormal. You won't find any normal lung tissue there. It's replaced with multiple cysts. So CLE, the current terminology, the correct terminology is CLO. So it's congenital lobar overinflation. And it's most common in the left upper lobe. The next is in the right middle lobe and then the right upper. It's very rare in the lower lobes. And the key finding is hyperinflation, so hypertranslucency of the involved lobe with compression of the remainder of the lobes and mediastinal shift to the contralateral side. Okay, so here's a 14-year-old female who has chest pain for 2 months. What do you find?
A mass in the right upper lobe.
Okay, so what sort of mass is it? Where is it coming from? Yeah,
Calcification.
yeah, very good. So, so within that mass, you're able to see these much brighter blobs within it, and that's calcification. So where is this coming from? So is it in the...
Because of malignancy.
So, okay, so what are the things that are going to help you tell where it's coming from? So look at the borders. Yeah, so you're going to need to look at the borders of the lesion. So that's the inferior border. You can see it quite well. There's the lateral border. You can see that quite well. Are you able to see a medial border to it or not?
No.
No, so you can't see a medial border. What does that indicate?
Atrial myxoma.
Sorry?
Right atrial myxoma.
So where's the right atrium on your X-ray?
Downstairs.
It's your right atrium, okay? That's where your atrial shadow will be. So up here is at the bottom is where all your heart chambers are. So at the top here, you will not get any heart chambers. That's where the SVC will come. That's your trachea. And then your brachiocephalic vessels will be there. So in this region, there's no heart. Heart is at the bottom. So the reason you're not seeing the medial border is because it's arising from the mediastinum. So this is a mediastinal origin of the mass. Now, can you tell which mediastinum it's coming in? What are the 3 divisions of the mediastinum? Yeah, anterior, middle, and posterior. Now, can you tell which mediastinum this is coming from?
Anterior.
Yeah, so you can see, so if you trace the hard border, you can make out the hard border. So that means it's not coming from the middle mediastinum. So whatever mediastinum it's coming from, the other structures in that compartment will be obscured. So because you're seeing the hard border, it tells you it's not coming from the middle mediastinum. Now, if you see this right paratracheal stripe is where your SVC will descend down. So normally you should see vascular shadow. That has been obscured. And then if you look at the upper border of the mass, again, you're not able to see a clear upper border. And the reason for that is as the mass goes up, it blends with the soft tissues of the neck, and that will obscure the upper border. So all of this tells you this is coming from the anterior mediastinum. And so anterior mediastinal mass with calcification within it, what is your diagnosis? So in general, yeah, teratoma. So mass anywhere with calcification, the first thing you're going to think of is a teratoma. So these are your differentials for anterior mediastinal mass, the 4 T's. Okay, thymoma, teratoma, thyroid. So very large thyroid can dip into the anterior mediastinum, and the other T is terrible lymphoma. Okay, so thymoma, teratoma, thyroid, and lymphoma are your differentials for anterior mediastinal mass. So here's a 13-year-old with chest pain. So if you apply the same principles that we talked about on the previous X-ray, what is this? Where is it arising from? So to start with, is this from the lung or is it from the mediastinum?
Mediastinum.
Yeah, why are you saying mediastinum?
Broad base towards mediastinum, middle border towards.
Yeah, so it's, yeah, you're right. So it's broad based towards the mediastinum and you're not seeing a medial border to it. Okay, so it's coming from the mediastinum. Now, can you tell me which mediastinum this is coming from?
Middle mediastinum.
Why do you say middle?
Because we can make out the cardiac border.
So if you can make out a border, that means it is not coming from that. So if it's in context, if it's coming from the middle mediastinum, the mass will be in contact with the heart and you will lose the heart border. So whatever structure it's in contact with, that border will be lost. All right, so that's known as a silhouette sign on an X-ray. If it's in contact with the structure, the border of that structure will be lost. Here, you have not lost the heart border. That means it is not coming from the heart. So it is not in the medial mediastinum. And this is the vessel shadow, the SVC shadow that's coming down. So that is in the anterior mediastinum. So since you're able to see that vessel shadow very well, that means it is not coming from the anterior mediastinum either. So what mediastinum are you left with? Posterior. The other clue that tells you that this is from the posterior mediastinum, yeah, is your upper border. You can see the upper border very well. So usually posterior mediastinal mass, when they go up, the posterior part of the lung will outline the upper border of the mass, and you can see an upper border quite well. And the next thing that tells you it's in the posterior mediastinum is the ribs. So if you look at the left side of the lung, so the ribs that I'm pointing to that come down like this are your anterior ribs, and the ribs that go down this way are your posterior ribs. Okay, so if you look over this mass here, look at the posterior ribs. Let me draw. So if you look at those ribs and you compare the two sides, are you able to make out that the gap between the ribs is increased? So compare the two sides, the one on the left and the one on the right. You can make out that the gap between these two ribs is raised. And if you look at that rib, you can see there is some thinning of that rib. So this posterior rib involvement again tells you that this mass has to be posterior to affect these ribs. So you know that this is a posterior mediastinal mass. What are you going to think of in a child?
Neuroblastoma.
So don't commit yourself to neuroblastoma. What is a broad umbrella term for it? Neurogenic tumor. Okay. Yeah, so neurogenic tumors will include neuroblastoma, ganglioneuroblastoma, ganglioneuroma, all of this. So just don't say neuroblastoma, just say neurogenic tumor. It can be any of those. So this turned out to be a ganglioneuroma. But on an X-ray, all you can say that it is a posterior mediastinal mass likely to be a neurogenic tumor. And these are your differentials. So most of these are neurogenic tumors. You can get neuroenteric cysts and also tumors from the nerve roots, schwannomas and neurofibroma. Okay, so now we look at some abdomen X-rays. Here is a 5-year-old with abdominal distension and vomiting. What are your findings here? So yeah, you're right that there are dilated loops. How can you tell whether this is small bowel or large bowel? Okay, so yes, these are all dilated loops. So if you look within the bowel, you can see these thin white lines running across. Now, these are valvulae conniventes. You will get these in small bowel loops. If you look at these lines, you can see they're running all the way across the lumen. So only the valvulae in the small bowel can do that. In a large bowel, you'll get mucosal folds known as a haustra. And the haustra will not run all the way across the lumen of the bowel. They'll stop short, okay? They'll run only for a small distance and then they'll stop. It will not run through the entire width of the bowel. So if you see these white lines covering the entire width of the bowel, they have to be small bowel. And the other thing that tells you that this is small bowel is the location. So small bowel loops will be centrally located, whereas your large bowel will be at the periphery of the abdomen. So this is dilated small bowel. And with that history, what is your diagnosis? So if you see dilated bowel, what are you going to say? Obstruction. Okay, so this is small bowel obstruction. Okay, so this is another child again with abdominal distension and vomiting. What do you find in this?
Generated large bubble.
Why are you saying large bowel?
Peripherally located with incomplete obstructions.
No, so again, this is all small bowels. If you look within these bowel loops, are you able to see these thin white lines? Again, here, you see these white lines running all the way across the lumen. And these are also centrally located. So all of these loops, your large bowel never come to the center of the abdomen here. All of these are dilated small bowel loops. And there's an additional finding here. What is that arrow pointing to?
Gallstone. Yes.
What is that? Can you see it's a calcific density blob? So calcification in the RAF, what are you thinking of?
Possibility of gallstone, yes.
Yeah, gallstone normally won't be that big. Yes, you're right. You could think of that. What else, particularly in the RAF, child with RAF pain? What are you going to think of?
Appendicolith.
Yeah, good. So that is an appendicolith. Okay, so that's an appendic. Whenever you see an appendicolith and then all of this pain and dilated loops, you're going to think of appendicitis causing small bowel obstruction. Okay, so here's a newborn with abdominal distension. This is like a typical Aunt Minnie. What is this?
Single bubbles.
Yeah, very good. Single bowel is diagnostic of?
Duodenal atresia.
No.
IHPs.
Single bubble is?
Congenital hypertrophic
Pyloric atresia. Okay. What is this? This is a neonate not tolerating feeds, vomiting.
Double bubble.
Yeah, so this is your double bubble. So the previous one, can you see this is a single bubble, whereas here you have two bubbles. There's one big bubble and then the other big bubble. This big bubble is your stomach, and then this is your proximal duodenum that's distended. So this is your double bubble duodenal atresia. Okay, here's a preterm who's 10 days old and has abdominal distension. What are the findings here?
NNEC.
NEC, yes. Why are you saying NEC? Because of the history. Yeah, so, with that history, that's what you've got to think of, preterm with abdominal distension. But what are the findings on the X-ray that tell you? Okay, so let me put some arrows. So can you see here in the stomach, you've got this sort of linear lucency going through it. And then in the RAF, you've got all this mottled, so little dots, black dots. So that's known as mottled lucencies. So these mottled lucencies and these linear lucencies indicate gas in the bowel wall. So dilated loops with gas in the bowel wall, this is NEC. Okay, this is a preterm, 1 week old who's not tolerating feeds, has abdominal distension. So history pretty similar to the previous case, but the findings are different. What do you find in this? Okay, so again, I'll give you some arrows to help you. So what is that arrow pointing to?
Total venous
Portal venous gas will be branching. So because the vessels are branching structures, right? So you'll see them as branching structures. You're not seeing branching lucencies here. So I've got a normal for you to compare with. So if you compare the right upper quadrant in the normal X-ray, where is this?
Similarity track.
So if you compare the two, are you able to make out any difference? So compare this normal one with that. So normally, so what is the structure that's there normally in the right upper quadrant? What is your normal organ in the right upper quadrant?
Liver.
Liver. Okay, so liver. So the reason it looks white here on an X-ray is because of the liver shadow. So this should be the normal whatever opacity that you see on an X-ray. But whereas in this abnormal child, are you able to make out that it looks much darker? It looks more lucent compared with the normal. Is that apparent or not?
Hyperlucent color.
Yeah, so you can see that it's much darker. It's much more lucent over the liver shadow. Why is that?
Pneumoperitoneum.
Yeah, good. So pneumoperitoneum. Why is it lucent over the liver in a pneumoperitoneum? So remember that the X-rays we take in a baby are all supine X-rays. Whenever your bowel ruptures and air escapes, so what will air do anywhere? It will rise up and go to the least dependent portion. So in a supine baby, the least dependent portion of the abdomen is anterior to the liver. So all of the free air will escape and will go there and accumulate anterior to the liver. And that is why you're getting that lucency. What are the other signs here that tell you that there is a pneumoperitoneum? So do you see, if you look between the bowel loop, you've got all these little triangles of gas. So gas within the bowel will never assume this sort of triangle sign. Whenever you see little triangles of gas, that means there is extraluminal gas. And if you look further down here in the left side, so this is your Wriggler sign where there's air outlining both sides of your bowel. So there's air within the bowel lumen, then air outside the bowel lumen. So the wall is illuminated by air on both sides, outlined by air on both sides. Now, if you're in doubt, you can get a supine translateral. And this is what I was talking about. There's the liver, and you can see the air is accumulated anterior to the liver. That is why there's that lucency on your supine radiograph. So this is a large pneumoperitoneum. Here's another example of pneumoperitoneum. Again, you can see there's this triangle of gas, and then you've got the Wriggler sign, and there's this lucency that's anterior to the liver. Here's a supine translator, and you can see there's a large amount of free gas that's accumulated beneath your anterior abdominal wall. Okay, so moving on, different set of pathology. This is 4-year-old who has abdominal distension for 2 weeks. What do you find on this? So again, compare the two sides, see if the bowel loops are distributed equally or not. So you're seeing, sorry?
Malrotation.
So never diagnose malrotation on a plain film. Okay, you need either ultrasound or a barium to do that. So on a plain film, never go by the loops are seen only on this side or only on that side, therefore it's malrotation. That doesn't work. What is it you're seeing here? Are you able to make out this big opacity here? Yeah, and then this is your normal properitoneal fat pad, this black line that's coming here. Whereas in this side, you can see it bulging out and all of the bowel loops are displaced to the other side. So what are you thinking in terms of? So what can cause opacity and displacement of the loops? There has to be a what there? No, a fecolith will not. Yeah. So whenever there is displacement of loops, you've got to think that there is a mass there. Only that is going to cause. Yeah. So this was the ultrasound of the same child. This is the kidney. And you can see there's a large heterogeneous mass that's arising from the kidney. So in a 4-year-old, what is your diagnosis going to be? A mass in the kidney?
Wills tumor.
Wilms tumor. Yeah, so that's what this was. So here's a 13-year-old girl who has pain abdomen and abdominal distension. What do you find here?
Homogeneous mass lesion in the lower.
Yeah, so how do you know there's a mass lesion there?
Loops are pushed up.
Yeah, very good. So all of the bowel loops are pushed up. So yes, you good that there's a mass and it's pushed up. So what is the other thing that tells you, because the bowel loops are pushed up, what can you infer from that? That this mass is coming from where? In order to push the loops up, where should this mass be coming from?
Pelvis.
Also the
Can this mass be coming from the liver and can it push the loops up?
No.
No. So where should it come from for it to push all the
No.
loops up?
Pelvis.
Yeah, very good. So it has to come from the pelvis for it to rise up like this and then push all the loops up. So in a girl child pelvic mass, what are you going to think of?
Ovarian.
Ovarian tumors.
This was an ovarian mass. Yeah, I think that was the last X-ray. Yeah, that's it. Thank you. So well done to the PGs for making it an interactive session. You guys picked up most of the findings.
That was a wonderful discussion. It was covering almost the whole extent of pediatric X-rays in a very short span. Congratulations to the speaker. Sir, can we go ahead with the next presentation, sir?
Yes,
or
sir.
any other further questions here?
Yes, sir. We had a fantastic presentation from Dr. Kanimoli. Superb.
Yeah.
Thank you, sir.
Yeah, over to Dr. Kannan, who takes it to the next level from the X-ray to the CT. So from this, we can definitely understand, even with the advanced imaging, the CT X-ray itself can give us a lot of clues and help us pick a lot of differentials and diagnosis. Yeah, over to Dr. Kannan.
Yeah, thank you, sir. Can you see my screen, sir? My screen is visible?
Yes.
Yeah, yes. So this, thank you for the opportunity, sir, first from the IAP. So this talk about the pediatric CT brains and CT necks. So CT for pediatric neurologists, usually like pediatric neurologists prefer MRI, but still sometimes they are asking pediatric CTs. Taking this CT. So here, anyone can make the finding here. So CTs are like an extension of X-rays. X-rays are 2D, but CTs are 3D. It's not as much complicated as X-rays. It's CT like simple to interpret. So if you take this, there is a foreign body in intraocular region. So the foreign bodies, it's actually contraindication for MRs. So especially the metallic foreign bodies. So there are few contraindications for MR. So PG anyone can tell the contraindication for MR, the absolute contraindications for MRI. So when you write the request form, that's very important.
Hello?
Hello? Contraindications to MRs.
Metallic implants.
Yeah, metallic implants, especially cochlear implants, aneurysm clips, the pacemakers. Pacemakers, yeah, we can modify it according to the machines, but the clinicians, we need to aware that the contraindications to MR, because sometimes the radiologist won't be there, the technician will put the child into the gantry, so sometimes it will be the catastrophic. So always important. So the contraindications for MR, to ask the clinical histories, any aneurysm clips, cochlear implants, pacemakers. This is very important. So this is the one of the indications for CTs. Sometimes you can see that there is a mass lesion in the left ocular with the calcification. So the calcification and the metallic, these are very hyperdense. The X-rays pass through the object, it can attenuate depending upon the content. So if the bones, the metallic, the calcification, that all are more dense, so these all will appear white. The air will appear black. The fluid will appear like in between. So the soft tissue, it comes around the 50 HU like stuff, it will come. So the child comes with white reflex, a calcified mass lesion in the intraocular area. What do you will think?
Retinoblastoma.
Yeah, my question for you, what are the DDs for the white reflex? So that is a retinoblastoma case.
Congenital cataract.
A congenital cataract, retinoblastomas, then
Congenital glaucoma.
congenital glaucoma, I doubt that usually won't do the congenital glaucomas. Main thing is the PHPV, Port's disease, toxocarious infections. These are produced the white reflex. So this child, 5 weeks child, a trivial trauma, right upper limb monoparesis with unilateral facial nerve palsy. We proceed with CT because of the trauma. There is a well-defined hypodensity. So this is hypodensity in the left basal ganglia region. So when you see this CT, the bones white, then this is the ventricle, the CSF fluid black, but not as much as air. But coming to this white matter and the gray matter. The white matter containing the myelins, the myelin contain the fat. So the fat usually less white than the gray matter. So the gray matter appear white here, and this white matter somewhat black here. So depending upon the content. So the bone white, the fluid, and this air and this white matter appears black because of the fat content, and the gray matter appear more white. So coming to this case, here there is a hypodense. So the infarct comes appear black. The hemorrhage will appear white. Okay, so here there is an infarct in the child, it is there. So we confirm with the MR there is a diffusion. It shows there is a basal ganglia infarct. But when we see the CT, there is a linear calcification here. The lenticulostriate calcification is here. So a trivial trauma followed by weakness, but no hemorrhages, there is an infarct. So what do you diagnose?
Mineralizing angiopathy.
Mineralizing microangiopathy. Good. So sometimes the SW, we can't pick up this calcification. So CT will very helpful to diagnose this mineralizing microangiopathy. Yeah, clinical will be classical. Yeah, trivial trauma followed by weakness will be there. So my question to you, what are the causes for the pediatric stroke? Anyone can put in the chat box also. What are the causes for the pediatric stroke?
Arteriopathies.
What?
Congenital cardiac disease.
Yeah, cardiac cause is the most common cause. So we need to screen the echo cardiac. Then yeah, arterial or venous. The arterial, there can be a hematological ones or the followed by infections like varicella, the focal cerebral arteriopathies, meningitis, the metabolic cause. Anyone can tell any metabolic cause the stroke?
Fabry's disease.
Yeah, Fabry's.
Homocystinuria.
Fabry, Melas. Yeah, Melas mitochondrial, Fabry's the lysosomal. There will be a hypertension. The thalamus will be there in the Fabry's with linear calcification. That also shows some arteriosclerosis will be there. Yeah, good. So here another calcification. The unilateral atrophy is here, and with the tram track calcification. And this is the child photo. I got it from the next.
Sturge fever.
Yeah, classic for Sturge Weber. So what the clinical manifestation will be the Sturge Weber?
Congenital hemiplegia.
Yeah, Caesar, the three, yeah, Caesar will be there. Sturge Weber, the port vein stains, glaucoma, where you get the glaucoma here, pubophthalmus will be here. And classically, we can get the tram-tram calcification with unilateral cerebral atrophy. So any other differential for the unilateral cerebral atrophy in children's?
Rasmussen encephalitis.
Yeah, Rasmussen will have the classic clinical history, will be the intractable epilepsy. It's a progressive in nature. EG classic finding will be there. Okay, Rasmussen, then Sturge Weber. Okay.
Hemimegalencephaly.
Hemimegalencephaly, it's the name itself, it shows it is actually the enlarged cerebral hemisphere. So this Sturge Weber, Perry Romberg, Rasmussen, sometimes the germinoma with the atrophy can comes. Sometimes the large MC or large ICA infarct can produce the hemiatrophies. So we are seeing so many calcifications. So what are the differentials for the calcification, like the white stuff? So physiologically it can be there. Sometimes the dural calcification associated with basal nervous syndrome also will be there. But few of the neoplasm, the genetic condition like Sturge Weber, tubers, infection like torch, herpes, metabolic hyperparathyroidism, hypo, pseudo hyper, these all can produce the calcifications. So this is the neonate child with multiple periventricular calcifications.
Cytomegalo.
Yeah, CME or toxo is CME. This turned to be the CME infections. The CME usually will be the periventricular. Toxo can produce the basal ganglia calcifications. This is another case, the child with a large mass lesion with calcification. Only few can produce the calcification in the tumors. The oligodendro, the peanut, choroid plexus, papillomas, these can only produce the calcifications. So this is the interesting one. This is the two different one. So this is the clinical picture, and here you can see the calcification in the subependymal region, and here you have the mass lesion. So what do you think?
Tuberous sclerosis.
Okay, tuberous sclerosis. This is a calcified nodules, and this is the tumors, SEGA, subependymal giant cell astrocytomas. Usually, we need to follow it up. So, what is this clinical finding?
Adenoma sebaceum.
Adenoma sebaceum. The triad will be there. So you need to avoid the triad, the tuberous sclerosis triad. So these are the few manifestations: the retinal hematomas, subependymal nodules in the heart, the rhabdomyomas, lungs, lamps, the liver, kidneys, angiomyolipoma, Sjogren patches, kyphomelatic macule, the periungual fibromas will be there in the tuberous sclerosis. So this I will tell the findings here. This is the basal ganglia calcification with Caesar on treatment, and here there is a basal ganglia calcification and also the calcification in the dentate nucleus also. So this I will tell. This is the Cockayani, the mitochondrial disease. Another one, this is the developmental delay, and there is a calcification in the basal ganglia, and there is a cyst in the anterior temporal lobe. This yeah, ICAD is good. This is the AGS. The ICAD is different. ICAD culture is different. So this actually comes as an interferonopathy, ICAD culture, and we proved this mutation also. So coming to the next category. So we saw the calcification. So here 16-year headache, memory loss. So the clinicians want to rule out the temporal lobe lesion because of the memory loss. So what is the finding here?
Bleed.
So there is a bleed. So the hypertension, there is a bleed. So the stroke, it will be hypo, like black, and this the bleed will be hyper. So the child comes with the bleed, the intraparenchymal bleed. What are the differentials you will think?
Any vascular anomalies, AV malformation.
Yeah, vascular anomalies, AVMs, aneurysm ruptures. But common thing is the CVT. So before that, the trauma is the first one. But the CVT, that's a danger. The dehydration, vomiting leads to CVT, and CVT produces the venous hemorrhage, venous hemorrhagic infarct will come. So this we proceed with MR, and there is a few extra vessels are coming, and we proved with the DSA also, and it's actually AVM rupture. It comes with bleed. So these are the causes for hemorrhage. But neonatal hemorrhage is the difference. That vitamin K deficiency, these all are come. But the pediatric age group, AVMs, cavernomas, coagulopathies, liver failure, DICs, thrombocytopenias, vasculitis, moya. These are the more common. We need to think about the causes. So that's a infarct, then the calcification, then the bleed. So coming to another group. So this child, a 4-year child, present with headache and vomiting. Here there is a large mass lesion in the posterior fossa with calcification, and it producing the obstruction over the fourth ventricle here, and it producing the upstream hydrocephalus. One thing I need to mention, see here, this mass compared with this white matter and this the white matter and the gray matter, this is more dense. So few of the mass appear more dense than the gray and white matter. So that's all the hyperdense mass lesions. That indicate these are the highly packed cells, the highly aggressive tumors. So few of the only will be appear like this. Anyone? Yeah, posterior fossa, hyperdense mass with calcification, it's a medulloblastoma. The lymphoma also can appear this type of hyperdense. The important things you need to understand, hyperdense is due to the high cellularity. Okay. Yeah, calcification more common with medulloblastoma. So pediatric, the few common tumors, the infratentorial posterior fossa tumors are juvenile pilocytic astrophenate, the medulloblastomas, ependymoma group, and the brainstem gliomas. Supratentorial ganglioglioma, phenate, DNET, it will come. So this is another child, 7 years, present with headache. Here they are large cyst with enhancing mural nodule. Same produce the mass effect over the fourth ventricle and produce the hydrocephalus. So cyst with mural nodule only few only can produce pleomorphic xanthoastrocytoma or the pilocytic astrocytoma, ganglioglioma. So this is the posterior fossa cyst with mural nodule. The diagnosis is the pilocytic astro. But this is the interesting one. Here the large lesion is seen in the brainstem. It's predominantly in the pons. It's expansile lesion, but it's a more hypo. It's more hypo. But it is in the midline tumor. Now these are the what the diagnosis you are thinking? A large lesion in the brainstem.
Gliomas.
Yeah, the midline gliomas. Usually these will be H3K27 mutant ones. It's highly aggressive. It's a poor prognosis. It's the midline gliomas, the brainstem gliomas. Usually H3K27 mutant ones. So what is LEAT? The child present with epilepsy. The epilepsy associated usually some low-grade tumors present with epilepsy. The low-grade developmental epilepsy associated brain tumors that all will be seen in the long. It will be seen for a long time. Usually that TNET, MVNTs, gangliogliomas, papillary glioneural tumors. These are the low-grade tumors. It will produce the seizure, epilepsy. So these are these terms we call it as a low-grade tumors, epilepsy associated brain tumors. It's important to diagnose this, but MR is the modality of choice, but you need to aware about these low-grade tumors. This 13-month child present with fever, vomiting, weight loss. This is our pediatric neurologist has a tough time with this child. Is now with us follow-up, but the finding here is there is a dilatation of the lateral ventricle third ventricle and fourth ventricle. Effacement of the cystins, all diffuse cerebral edema is there. So the child present with fever, weight loss, vomiting, and the communicating hydrocephalus.
TB meningitis.
Yeah, TB meningitis. And when you see here, there is a hypodensity is coming. So that's the infarcts are coming here. So why these infarcts are coming here?
Like this.
Yeah, this is a meningitis child, but there is a infarcts are in the basal ganglia. Why it's this infarcts coming? Here there is a mild enhancement of the cystins also there, but this MR image clearly shows there is a enhancement of the basal cystine. And closely see here, this is the left MCA. With the MCA surrounding, there is an enhancement is coming. So that is indicating
Basal exudates.
yeah, this is the basal exudate. Correct, good. So the basal exudates are there, but it's extend along the left MCA, that surrounding the MCA, there is a exudates are coming. There is an inflammation in the vessel, left MCA. So this is actually meningitis. Then the ventriculitis, the periventricular ooze are coming. Then this is the vasculitis, the MCA vasculitis. Then this is the infarct. So this is the how the TB meningitis is progressing. This is the we are treating this and the child is getting better, but it's not only with ATT. That Sir can clarify this. What the drugs he used for this child.
Yeah, in the clinical therapeutics, the difficulty in this child was the child went into TB iris paradoxical reactions, and we had to use infliximab for this child. I think is it just I think this it is mentioned as 13 months.
Oh, sorry, sir.
It is I think it is 13 years, right?
13 years.
Yeah, yeah. This is the child who we started who initially presented, and for the child was started on ATT. After 1 month of clinical improvement, the child significantly worsened, and the child would have got CT at least 5 to 6 times, I think so. So, and there was a significant paradoxical worsening, and along with ATT, the child is on infliximab, with which the child is getting stabilized now, and this child is doing clinically better now, and all the complications of TB meningitis, the CT findings we could see in this child. Like as Dr. Kannan mentioned, this area is called the tubercular zone, where this caudate basal ganglia will very often go for vasculitic strokes. This caudate, anterior thalamus, and anterior limbic, anterior internal capsule, anterior thalamus, and caudate. These are some important areas where they will go for vasculitic strokes. So this is the tubercular zone, and as he rightly mentioned, you can see the evolving stroke, evolving vasculitic areas in this zone. Yeah.
Yeah, thank you, sir. So here another child present with no perinatal history, but there is a dilated lateral ventricle and third ventricle. So, but the fourth ventricle is normal. So here the aqueduct region coming. So this is actually aqueduct stenosis. So how this CSF flow it's going. So from lateral ventricle, then the foramen of Monro to the third ventricle, then aqueduct. Here the aqueduct comings to the aqueduct to fourth ventricle. From that foramen Magendie and Lusca, then the arachnoid granulation will absorb that. Then the choroid plexus again it will secrete. So the important to imaging in hydrocephalus is the clinician's question will be it's a communicating or non-communicating. That's they want to know. So what is communicating? What is non-communicating? Anyone can tell what is communicating? What is non-communicating? That's otherwise we call obstructive or non-obstructive. So the communicating ones are like over secretion like stuff, that choroid plexus, papilloma, that all produce the communicating one, or otherwise the obstruction at the level of that arachnoid granulations levels. All the four ventricles are communicating. Obstruction will be like absorption level or over secretion, like subarachnoid hemorrhage, that the hemostrident deposit can obstruct or the meningitis can obstruct. The obstructed one from the pathway, the lateral ventricle to third ventricle, like foramen Monro level, some tumors, or the aqueduct level, some tumors, or sometimes in the fourth ventricle, some tumors in the posterior vasa causing compression. So these are the obstructive types. So the clinician's question will be, it's communicating or non-communicating. It's a what is the treatment will be differ for these two conditions, these two. So this I got from the net because we usually don't get this. The child has a subdural hemorrhage and he has the metaphyseal corner injury, skull, and the posterior fossa rib fractures. So the multiple injuries, that subdural hemorrhage. So what do you think?
Battered baby syndrome. Battered baby syndrome.
Yeah, battered baby or non-accidental traumas, because these are the posterior ribs or the skull. You need more force. This subdural hemorrhage, because of that shaking, you can get the hemorrhages. So these few of the specific signs in the radiology is that the metaphyseal or ribs fracture, especially posterior scapula, spinous fracture, or sternal fractures. Clinically, the retinal hemorrhage may be the clue for the non-accidental trauma. But there are so many DDs are there. Can be the accidental injuries or coagulopathies. The multiple fracture can happen with osteogenesis imperfecta. Menkes, inborn and metabolism can produce the subdural effusions also. So this is the subdural effusions, just the fluid in the frontal lobe. Why I put this? There is some up to 2 years, there will be the enlargement of the extra CSF space will be there, especially in the frontal region. That's called the benign enlargement of frontal region, because that time the skull more growth than the brain, so you have that more place for the CSF. You get this enlargement of that CSF space will be in the frontal region. So that's actually benign condition. But the subdural effusions can happen in the child, especially any DDs you can give the subdural effusion. Yeah, trauma can produce that. Subdural bleed can happen with non-accidental trauma. Any metabolic disease can produce the subdural effusions. Yeah, subdural effusions, the bat wing sign and the basal ganglia abnormality will happen with the glutaric asturias. Sometimes the biotinase deficiency also produce that subdural efficiency, or the Menkes disease also can produce the subdural effusions. So another one interesting, this also child also present with subdural effusions, but this actually the person with the lateral neck mass. It's a hard mass, so we initially thought it could be the lymphadenitis, but we do this CT. I saw this actually there is a subdural effusion is here. So in the bone window, there is a permeative type of lesions are coming here. Anyone have the clue? So just like crossing that area, I asked to cover this brain. This child comes for the CT neck only, but there is a finding in the brain. Subdural, it's not an effusion, it's like a moss lesion. It's a thick like sheet like this, and this is a permeative like, and this child will have the myoclonus.
Neuroblastoma.
Huh?
Neuroblastoma.
Yeah, neuroblastoma. So I cover that same sitting. We cover the abdomen. There is a large paraotic lesion here with the calcification, and it's proven neuroblastoma, and child went for the treatment. So this is the important in the pediatric radiology. You need to search for the clue. It can be anywhere in the body. So you need good clinical exam, clinical DDs. Then you need to search for the clues and come and join the dots and make the diagnosis. That's interesting in the pediatric radiology. So sometimes you will have this type of just a dip in the skull, just scalloping like stuff. ping pong skull fracture. It's like a green stick because that bones are not mature. It's hard to break. So you will have this type of indentation. So this child has coming with spur. It's enlarging skull mass in the in this left parietal region. So this enlarging mass. It's a progressively enlarging. When we ask the history, he has a trauma 2 years back, and there is a surgery. Surgery. Now the child has the convulsions and right hemiparesis, and here it's a growing. Enlarging skull mass. This is where the clinical examination, the clinical history taking is very important. What do you think this?
Growing skull fracture.
Yeah, growing skull fracture or the leptomeningeal cyst. This actually there is a old trauma. There is epilepsy due to this gliosis. Because of that, brain is growing. There will be the gliosis will extend outside. So that's like enlarging skull mass. The child present with the enlarging skull mass. So we need to ask the history, any previous trauma or previous surgery is there. Then usually it will be like very soft, because usually that encephalomalacia will replaced by CSF, usually will like soft. So this 28 weeks pain and swelling in the mandible region. So here it's like periosteates there, expanding cortex is there. This is a classic spot they will put in the exam. And there is a mild surrounding inflammation also there. It's involving the mandible bone. What? Yeah, cuff is. So how the clinical manifestation of the cuff is?
Cry.
Irritable cry, and there can be a swelling and warmth. That area also will be there. What's the lab parameter you will ask? Usually the alkaline phosphatase will be raised. The treatment for this cuff is, but it is actually the last diagnosis, because it's always confusing with the osteomyelitis with cuffs. The ESR also will be increased in both conditions. But the classical location and not that much soft tissue swelling, we think of cuffs usually. The treatment, anyone, the treatment for the cuffs? Infantile cortical hyperostosis, what's the treatment? So you read. So this another condition usually they refer for the CT. Here, these are the coronal sutures, and this the sagittal sutures should come here. But here the sagittal sutures are not there. So the premature fusion of the sagittal suture. What is the condition?
Craniosynostosis.
Yeah, craniosynostosis. Good. So it is difficult to remember the name, but usually they pre-op they will do, and they do some surgical. They put the lines here and for the growing brains. So this is a trichoncopoly for the metapic suture, the sagittal scapulocephali, this is the brachycephaly and plagiocephalys. This you need to refer. It's difficult to remember this, but this 6-year child has a present with a swelling in the frontal. The CT shows the lytic lesion. He has a history of trauma. That's why we put in the CT. History of febrile seizure also there. But here, when you see this type of lytic lesion, no periosteatis, no significant soft tissue. We called this with beveled edges, and I give the DDs, one of the main DDs. So we proceed with MR. There is a collapse of one vertebra. The vertebra plana is here. So the vertebra plana with a well-defined lytic lesion in the skull. What's the diagnosis?
Long history.
Yeah, LCH. Good. So So the lytic lesion, there can be so many DDs, but with vertebra plana LCH. So there is a 3 types of LCH. You all knows this: the multi-system involvement, unisystem involvement, then the Hanseler Christian disease. So these are the different clinical manifestation will be there. So the treatment also will be differ. So here this child has retinal angiomas, the orbit, we meet to orbit, and he has the renal cyst, and he has the renal cell carcinoma and pancreatic cyst, and there is a cerebellar hemangioblastoma in the spinal cord. What syndrome?
Von Hippel-Lindau.
VHL, von Hippel-Lindau syndrome. So the clinical manifestation, retinal angiomas, pulmonary hemangiomas, hemangioblastomas, PO and RCC, pancreatic cyst will be there. So this 14-year child present with epistaxis through left nostril. When we do the CT, there is a mass lesion in the retromaxillary region, and it shows intense enhancement. This is the MR image. This is the CT image. So there is a mass lesion in the retromaxillary, a male child present with epistaxis. JNA, juvenile nasoangiofibrosis, the endovascular. Yeah, correct. The endovascular treatment also there for this. So here this child present with midline swelling, slightly painful, and move with deglutition. It's at the level of hyoid. So moving with the deglutition, midline swelling. What?
Thyroglossal cyst.
Yeah, thyroglossal cyst. So it can be come from foramen cecum, the base of the tongue to below the hyoid also. The surgery for this, the cistern operations. So as a radiological, if it is a cyst in the midline, it's a ranula, the sublingual region. If it's come in the mandibular, the blunging ranula. Thyroglossal cyst come here, the hyoid region. It can come from base of the tongue to here. And the dermoid, it has the fat density. If it comes in the lateral side of the neck, the bronchial cleft cyst, usually the classic location will be there. The 4 types will be there. The pre-auricular, the first type, and the neck between the IC and ECA, the brachial 2 will become far more lateral. The 3 will come. Then the larynx level, the 4 will become. Then the multiple location, the cystic lymphangioma will come. Usually the cystic lymphangioma we can treat with sclero. So this is a different one. So I explained this. This is in the submandible region, the cystic lesion between the mylohyoid. So what do you think? A cystic lesion, ranula, the blunging granulas can be in the sublingual or in the mylohyoid. This child assist in the lateral area and operated IND done, but it's recurrent. So whenever the child IND done with come with the recurrent cystic swelling, think about bronchial collapses. You need to take the full tract, otherwise the recurrence will come. And this is we treat with sclero, the multiple cystic with the septations. It's incinate between the areas. That's a cystic lymphangiomas, cervical cystic lymphangiomas. So coming to the neck solid lesions, the most commonest is the reactive nodes, lymphadenitis and lymphoma. We have one separate, the previous class happened in the lymphadenitis, the cervical lymphadenitis, the DDs, the wonderful cases they showed, the cat's disease, but most common is the TB for us. The solid lesions are like I show you the neuroblastoma, the neurofibromas, the aggressive lesions like rhabdomyosarcoma, or the child present with torticollis, the enlargement of the sternocleidomastoid, the fibromatosis coli. These will comes. But this one interesting one, the 5-year child swelling in the left side of neck region, weight loss, left facial and hemiatrophy. So that's a 12th nerve also involved. And here the lesion is come in the left carotid space. It shows intense enhancement and it shows diffusion restriction. And the lesion is seen hypo on T2. So the lateral neck mass, usually if it goes involving the multiple cranial nerves, usually the schwannomas will come, the NF1, the NF2 schwannomas. but it won't show this much of diffusion restriction and this much of enhancement. Yeah, well-defined lesion. See, this is a well-defined one. Any DDs, anyone? So solid rhabdo can come, neuroblastoma can come, neurofibroma can come. But this turned out to become a AL, acute lymphoblastic lymphoma. Sometimes surprise always will be there. So thank you for your attentions. Any doubts?
Thank you, sir. Postgraduate, any doubts you can post in the chat box.
Can ask Sudhagar sir also as a pediatric neuroradiologist. Sir.
Yeah, that was a wonderful discussion. And I think both Dr. Kanimoli and Dr. Kannan justified the name resource person. Like they have it was both resourceful, like lot of cases, and almost you have covered a n number of cases. Yeah. I would like to add today the CT in pediatric from pediatric neurology. Whenever most of the things we will be preferring MRI, but when we think of some calcifications or during an acute stroke, usually we immediately go for CT. And one more thing is in pediatric stroke, this trivial fall thing. Usually this mineralizing angiopathy is picked up only in CT, and we may miss that in the MRI. So that's one very good take home from your presentation. And this calcifications, if you are suspecting calcifications for any differentials, kindly go ahead with CT. Along with MRI also, sometimes if you say to the radiologist, they will do along with the MRI. That will help in narrowing our differentials.
Sir, Balasan sir.
Actually, I thought I may not be able to sit for 1.5 hours in this session, and I wanted to leave actually, but I stuck to my chair and I was listening for the whole proceedings. And thank you very much, both the radiologists, Dr. Kanimoli, extraordinary, and Dr. Kannan, you are also too good. And we learned a lot from you today, how to interpret X-ray and CT, X-ray of the chest and abdomen, CT of the brain and the neck. Thank you very much. We had a wonderful learning experience today evening. Thank you, both of you. And I also thank Dr. Sudhagar Karnagaran for moderating. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir. Thank you, Dr. Kannan and Dr. Kanimoli for the wonderful interactive session. And Dr. Sudhagar for mentoring the postgraduates. Hope to see you in another session and another next month.